So welcome to Asking the Tough Questions, RVCT, and Sensitive Demographic Data. My name is Gal Tabachnik, and I will be your host for today. So today's faculty have all signed a declaration of disclosure and have indicated that they have nothing to disclose. So these are our objectives for today's webinar. So now let me introduce today's moderator and speaker. Dr. Lisa Pascopella is a senior epidemiologist with the Tuberculosis Control Branch at the California Department of Public Health. She has over 20 years of experience in TB epidemiology, research, and analysis, generating evidence to guide TB program activities and policies. She was awarded her MPH by UC Berkeley, her PhD by Albert Einstein College of Medicine Graduate Division, and her BS degree by Columbia University in New York. She's received honors during her postdoctoral work at the National Institutes of Health, and she's also worked for the Curry International Tuberculosis Center to oversee a regional TB program improvement project that was funded by the Centers for Disease Control and Prevention. I'm also going to quickly introduce today's two other speakers. So Luis Peñate is a trainer at the California Prevention Training Center, where he develops and delivers skills-based trainings for disease intervention professionals. Luis previously worked on the front lines of the fight against HIV in Los Angeles and Detroit, and is experienced in sexual health education, HIV, STI testing and counseling, and motivational interviewing and case management. Maria Carter is a quality assurance epidemiologist at the TB Control Branch at the California Department of Public Health. She leads the RVCT trainings and provides technical support to the California local health jurisdictions on RVCT surveillance and TB case reporting in CalReady. So it is my pleasure now to pass it off to Dr. Lisa Pascopella, who will get us started today.
So good morning and good afternoon to everyone that is present across the U.S. From the TB branch that's located in Richmond, California. So we're going to start today trying to give the rationale for why should we be asking the tough questions of our clients when we're trying to do case management, work with our clients to get them through TB treatment. Whenever we interact with our clients. We're collecting a lot of data at all times. Okay, so the reason why we need to ask these questions of our clients, and when we say the tough questions, we're talking about the ones that feel kind of sensitive for you to ask, about social characteristics, behavioral characteristics. It's because that some of these are risk factors. And what I mean by risk factors is that a risk factor increases the risk to either be even be exposed and infected by tuberculosis, or could be related to treatment outcomes of TB. If someone has a risk of not being able to complete treatment, for example, or for the worst case scenario is risks that may make an individual more likely to die with tuberculosis. And so because these risks are differentially distributed across different groups of people, it's considered a health disparity. And we as public health workers, one of the things that's part of our job is to identify and address this so that every individual, no matter what group they belong to, gets the same care and best care possible. So another way of putting it is that we collect data on each individual that has a reportable condition for the purpose of improving the health of the public. And kind of the way this works in tuberculosis is that at the local level, you, for example, will do client interviews where you ask questions of the clients that you're interacting with. And what we then do in other parts of the local health department and the state health department is to complete data that we collect, that you all collect from the interviews, put it in a certain format called the RVCT, which is actually part of our state and national TB surveillance system. And why do we have a TB surveillance system? Well, we analyze the data, again, that you originally collected directly from your client to monitor the disease trends and really to identify areas where we can improve our program work at local and state levels and even national levels. And again, with the thought of focusing resources and efforts towards the communities that experience disparities in tuberculosis. So some examples of how we use the data to improve public health. We want to ensure adequate prevention and care. So in the area of tuberculosis, with the known risks, individuals that are born outside the United States or experience homelessness or incarceration or are using substances may be at increased risk of TB. And we look at the data also to see if, as we develop new guidance through the years, as we get more evidence from client interviews, as well as research studies that are separate from TB surveillance, we can use that evidence to continue to learn at the program level. What is the best way to prevent TB and to care for TB patients? So let's review some known tuberculosis risks. We know that individuals born in most countries outside the United States were more likely to be exposed to TB in those countries than they are in the United States. We also know that outbreaks of TB have occurred in shelters, among individuals living outside of a home, or in single-room occupancy hotels. In the past, and perhaps still in some places, individuals who are or have been incarcerated are at greater risk of TB. And outbreaks have also been linked to areas where folks gather around substance use and using alcohol. So let's dive into a few of these risks in a little more detail. What we know is when epidemiologists like to use rates, which means the number of individuals that have tuberculosis per 100,000 of a population living in a particular place. And in the United States, this slide is from the Centers for Disease Control and Prevention. In the year 2022, the rate of TB among US-born people was 0.8 per 100,000 people, pretty low. And the rate among non-US born was 13 per 100,000 people, which is a 16-fold difference. So that means being born outside the US when you live in the US is a greater risk for TB than if you're born in the US. Okay, so here in California, we have guidelines, and again, other states and programs and or cities, counties have their own guidelines because the epidemiology of TB could be different among different places in the United States. But here in California, we know that actually our non-US born individuals are at even greater risk than across the United States compared to US born individuals. So we have screening guidelines to prevent TB, to identify latent TB infection before it becomes active TB disease. And we work with our private providers to make this happen. Here is an example of a form that we use to help our primary care providers identify individuals who are at risk of TB. And here you can see that any birth, travel, or residence for at least 1 month in a different country is a risk, and these folks should be tested for latent TB infection and active TB disease ruled out in that individual. And then there's a few other risks that have been identified, and here we'll also talk about homelessness or incarceration. So what about how TB rates among different racial and ethnic groups? Well, we know that US-born white people have the lowest TB rates here in the United States. Non-US-born Asian people have very high TB rates. And in addition to looking at TB incidence, the risk of death with TB is increased for certain groups. Okay, so compared to the US-born white people, an analysis of national TB surveillance data demonstrated that US-born Black, Hispanic, and Native American people with TB had an increased risk of death and treatment discontinuation. This is another example of a disparity that we do not abide by. We need to do something about this. Here is another Centers for Disease Control and slide on TB incidence rates by race ethnicity. There's a lot of information here because we have multiple years, which is giving us a trend. But really what I want you to focus on is this idea that the white TB rates are in orange here, and Asian is in blue, and Native Hawaiian or other Pacific Islanders in green. So you can see that through all the years, for the most part, whites have the lowest TB rates, and Asian and Native Hawaiian or Pacific Islanders have higher rates of TB in the United States. So let's go on to unpack this a little bit more. We know that race and ethnicity is a social construct. There's no biologic reason for differential risk of TB, okay? But there are underlying reasons for their differential distribution of TB risks, okay? And we know that different racial and ethnic groups in the United States have different levels of socioeconomic status. Here in California, we actually collect additional data on educational attainment for individuals with TB because we found this is a risk. Individuals with lower education are more likely to have TB compared to those with more education. We also know that there's a differential distribution of factors that contribute to a greater risk of chronic conditions. Differs by race and ethnicity here in the United States. And some of these conditions include diabetes, immune suppression, kidney disease. And also there's access to care factors that may underlie the different risks among the different groups of people, as well as other factors that we may or may not know about. So what do we do with all this information about differential risk? Well, we need to focus our public health interventions on the communities that have the highest risk of TB. Start with those, right? So we want to have earlier TB diagnosis, which would include rapid evaluation of close contacts to individuals with TB. We want to build awareness of TB among individuals who live in those communities at higher risk, as well as their providers. We want to do better prevention in those places, as well as work across our programs. TB is an infectious disease, but we need to work with programs that do chronic disease as well, so that we can work together on really improving the outcomes for individuals who have both TB and chronic disease. So getting to some of the specifics of the questions that we're going to be talking about today, then Maria and Luis will give great detail in terms of how to ask these questions. I'm just telling you a little bit more about, again, California as a state. We have regulatory codes that support the collection, analysis, and use specifically of sexual orientation, gender identity, and race ethnicity data. And the reason is to understand the extent of health disparities that are experienced by LGBTQ plus people and individuals of racial ethnic groups. And again, with the goal of improving our government programs for people that are in need of care and assistance. So why think about gender identity and tuberculosis, okay? Well, what we do know is that a greater percent of individuals with TB are men compared to women, which means that men are at higher risk of TB than women, which means that sex assigned at birth is a risk for TB. Now, we don't really know about this disparity, like what are the possible reasons for men being at greater risk of TB than women. It could be biology. Maybe there's some sort of hormonal influence. It could be behavior. Across the world, men are more likely to smoke tobacco, which is a risk for TB, or there could be a combination. So you could see how knowing how someone identifies their gender is important to understand a potential TB risk disparity. And we currently don't collect data on gender identity at this point in time. And that's one of the foci of our training today. Sexual orientation, we can ask the same question. Why do we need to know about sexual orientation again with tuberculosis? Well, we don't really have much research on the impact of sexual orientation on TB risk. We do know a lot about sexual orientation and risk of HIV, syphilis. So men who identify as men who have sex with men are at higher risk than those who identify with other sexual orientations. We also know that there's some overlapping risks with HIV and TB. And so, again, knowing how someone identifies their sexual orientation is important to better understand a potential TB risk disparity. So anyway, I just want to encourage you and inspire you as we move forward through this webinar, that there is a rationale for your collecting these additional pieces of data on the clients. You are the face of public health for the client. You are demonstrating the interest and need of the individual client in front of you. And some of these data that you may collect are directly and urgently needed for the appropriate TB care, for example, very specific medical questions. And some of the data won't be directly relevant in the moment with your client, but as we look at the data through time, again, we will be focusing on improving the health of our future clients, okay, through better TB prevention, detection, and treatment approaches. So now I'm going to hand it off to Maria and Luis.
Thank you, Lisa. So now Luis and I are switching gears into some sensitive demographic questions that are collected in the RVCT. I will be reviewing the RVCT questions and definitions, and Luis will be reviewing some recommendations, tips, and practices on how to ask these tough questions. I'll start with the RVCT. The RVCT is the report of verified case of tuberculosis, which is essentially the data collection form used for TB surveillance data. Like Lisa mentioned, local TB programs may be using their own TB case reporting forms or client interview forms. And any of these forms may be used to gather data or information to complete this standardized RVCT surveillance form. Some US reporting jurisdictions may also be using a modified version of the RVCT form that is unique to them. And during this webinar, we're going to be sharing images of the California RVCT form and a couple questions that are unique in the California RVCT. Here we have an overview of the sensitive questions that we're going to be focusing on during this webinar. First, we have gender identity and sexual orientation, both of which are unique questions in the California RVCT form. Then we have sex at birth, which is one of the standard RVCT questions, as well as race and ethnicity. And then we're going to wrap it up with a few other RVCT questions related to social and behavioral risk factors, which include incarceration, homelessness, and drug and alcohol use.
Thank you, Maria. So now I'm going to go ahead and, as Maria mentioned, I'm going to discuss some of tips and different practices that are going to help you ask some of these tough questions. So we are now going to go ahead and talk about something that I find very important. One of our first recommendations to be able to ask these tough questions, it's set the stage for the conversation. So to effectively set the stage, it's really, really helpful to introduce the demographic questions to all your clients. So I'm going to go ahead and review a couple of statements that you can use to introduce these questions so that you can have a smoother kind of takeoff into asking what could be, tough questions to ask and answer for folks. So the first statement that you can say is, next, I have a list of questions for you about your identity. And this statement helps the client to know what is coming so that they don't feel like they're being ambushed and like these questions are coming out of nowhere. If you are using a similar phrase as you move through different parts of the interview, so if you talk about where they think they might have been exposed to other questions in your interview, if you use something similar to this statement, like next I'm going to ask you a question about where you might have probably been exposed, something like that. If you pepper that throughout your interview, it's going to seem more standard once you get to the questions about demographics, and this will help the person realize that This is a standard part of the interview. You're not picking on them or you're not asking the specific questions because you're making an assumption about them or their identity. Another thing that you can say that we recommend that you say as you introduce and set the stage to this questions is letting people know that you ask these questions of everyone. And this statement is really, really helpful because it normalizes the questions. You let that person know that every single person that you talk to is asked these questions. And again, it lets them know that this is a standard question and that you're not making any assumptions about them. And that's the reason why you're asking the questions. Something else that you can also add and that we recommend that you add to your introduction of these demographic questions is saying something like, we asked this to understand which communities TB in this case is impacting. And this is directly correlated to what Lisa was mentioning earlier. You provide the rationale for that person so that they understand why you're asking these questions. And in that, once people know why you're asking those questions, people feel more inclined to answer if you let them know how that information is being used and also how the information is going to benefit their communities. So now we're going to go ahead and now that we talked about how to set the stage, I'm going to go ahead and share with you some things to avoid when you're setting the stage to ask these demographic questions. So let's start with the first one. So try to avoid telling the client, these questions may make you feel uncomfortable. So when you say a statement like that, you might actually be introducing discomfort to the conversation that the person might not have. Maybe that person feels comfortable asking that question. And now you have introduced that level of discomfort into the conversation, which we want to avoid. Um, this statement also makes it seem like having a conversation about these topics should be taboo, or it makes it seem like it's inappropriate, when in fact our job should be to normalize asking these questions and remind people of the really important reasons as to why we're asking these questions. Another thing you should try to avoid when you're introducing or setting the stage for this question is telling the client that they can decline the questions at the start of this section. And it's really important. There's a caveat for this one. Unless you tell them that they can decline every single one of the questions that you've asked them throughout your interview before you even ask those questions, it's important not to say it and target and say this to the specific questions that you're asking, the demographic questions, because again, then you're signaling these questions as not standard part of your interview. You're making it seem like people should be ashamed, or these are discussions that you shouldn't have with people, which can, lead to discomfort when there might not be none, or exacerbate any discomfort that might already be there. Another thing that you can avoid, that you should be avoiding when you're introducing these questions, is treating this section different than any other section in your interview. And that includes maybe switching the tone of your voice when you ask these questions, or changing up the cadence of how you speak. And that could be, the rhythm that you have when you ask these questions. Maybe you're emphasizing or pausing between words. So if you ask someone a question like, what is your sex assigned at birth? That makes it seem like this question is taboo, is not standard, right? It makes it seem like you're uncomfortable, and we definitely don't want people to feel that. So if you sound uncomfortable, and you're treating these questions different than others, that can make that person feel uncomfortable. So now I'm going to put all the suggestions together that I just talked about. And it would be really important, and something that you can do ahead of having your interviews, is to craft and memorize your own introductory statement. If you're asking these questions of everyone, then this is something that you should already have in the back of your pocket, and that you can just use once you get to this section of the interview. Something like what the statement is that we have here could be helpful, and it's very quick. So I'm going to go ahead and read it for everyone here. You can say something like, I'm going to move on to ask you a series of questions about how you identify, and your responses helps us ensure that we know who is being affected by TB in our community, and it also helps us provide the best services to all members of our community. I want to remind you that we ask these questions of everyone that we interview. So please know that all of your responses are kept confidential and are only used for the purposes of understanding the big picture of how TB is affecting our community. So that's just a very simple way to introduce these questions and review how these questions are the answers to these questions are going to be helpful for their communities. So if someone does ask you if they have to answer those questions, I'm going to share an example of what you can say. For example, after you've already, introduced the questions, you can say, all these questions are voluntary, and you can choose to skip any questions at any time. But we hope that you will answer these questions so that you can help us ensure that all members of our community are able to live a healthy life. So that's just a statement to share if, people ask if they have to answer these questions about demographic information. So now we're going to go ahead and look at some of these questions more in detail. And to do that, Maria is going to go ahead and review them with you.
Thanks, Louise. Let's get started with those questions. Okay, so the California RVCT form asks about a person's gender and sex at birth as two separate questions. The California RVCT question on gender asked about a person's current gender identity, and it is intended to reflect their self-identify information. This question allows for gender diversity and response options, as you can see listed here, as well as the options to answer that their identity is not listed if none of these options apply to the person, as well as the option to decline to answer if the person does not feel comfortable sharing this information. Next slide, please. The separate question about sex at birth is standard in the RVCT. This question is intended to establish the biological sex recorded for the person at birth. The response options include male, female, and unknown.
Thank you, Maria, for sharing a little bit more about how these questions are presented in the RVCT forms. I'm going to go ahead and now, this is the kind of more participatory section of our training. We want to hear from you. We want to make this interactive. So we're going to ask you to answer a poll so that we can learn in, a very more interactive way. So go ahead and of the options that you see here on your screen based on what Maria shared with us, go ahead and let us know what you think is the best way to ask a patient about their gender identity. So it's great to see that a majority of you, 84% of you, picked what we think would be the best way of asking this question. The reason why this question, this is the best way to ask this question is because it's an open-ended way of asking the question. That means that the person, it's not a yes or no answer, and the person has to come up with an answer on their own, which lets you know how they self-identify, which is exactly what Maria mentioned, right? We are asking these questions to reflect the person's self-identified information. The reason why A is incorrect is because it forces people into a binary, and it also incorrectly uses the sex terms as opposed to gender terms. And we're going to talk about that in just a few slides. B is a great way of asking about sex assigned at birth, but remember, we're asking about gender identity at this point. And then D uses the gender terms men and women, which is great, but it narrows that choice into a binary, which for many people, they might not identify as a man or a woman. So asking it in a more open-ended way would allow you to hear responses for people who identify as non-binary or genderqueer. So now let's go ahead and look at a helpful tip for asking these questions. So if someone does not know how to answer your questions, there's one thing that you can do that's very easy and helpful. You can just list all the options that are available for them. So if someone doesn't know what gender identity means, then it's best to not try to define it because that shouldn't be your job. It's a little bit higher above our pay grade, right? So we can just ask them more easily, of the options that we have listed in our data collection tool, which one do you identify with? So you can ask them, do you identify as female, genderqueer or non-binary, male, trans female or trans woman, trans male or trans man, or is your identity not listed here? That's a really good way of asking a question if someone doesn't really know what you mean, and they can decide for themselves which of the categories that you have available to you fits them the best. So although identity not listed or other may be listed alphabetically in your list, we do suggest that you save that option for the very, very last option that you read out to someone, because it is helpful for someone to hear all the options available to them. And if none of them fit, then you can choose, identity not listed. And in this case, you might want to let the person know that you will, mark them down as identity not listed instead of other. Even if in your tool it does say other, it might make people feel uncomfortable if you let them know that they are other, because that is literally othering that person. And just so that everyone knows here on the webinar, othering is when individuals or groups are treated or marked as different or inferior from dominant social groups in our society. And we definitely don't want to make people feel that way. That will definitely decrease the rapport that you have with someone. So let's go ahead and look at our next poll question here. So go ahead and let us know if you think this is true or false. You can guess someone's gender identity based on what they wear, how they sound, how they look, or how they act. And a majority of you, let's share the results, got the correct answer. Great. The answer here is false. It's important that we never assume someone's gender based on their voice, especially if you're on the phone with them, and if you're in person with them, that you avoid trying to make assumptions based on how they look or what they wear. People of all genders express their gender identity in different ways. We all do this through the clothes that we wear, how we wear our hair, how we talk, and then other various ways in which we walk around in the world. Sometimes those may correspond to the gender norms or stereotypes of our society. For example, men have short hair, or men don't wear makeup, and ideas like men don't cry. But sometimes those things don't match up, right? Sometimes men do wear makeup. Sometimes men do wear nail polish. I usually do, but I'm not today. And how people express their gender not always corresponds with how they identify. And it's definitely also doesn't always align with other identities like sexual orientation as well. So remember not to make any assumptions based on how someone sounds or someone looks like. So here's another hot tip for everyone here about sex assigned at birth, which is the second category of question that Maria shared with us. When asking about someone's sex at birth, which you might also know as sex assigned at birth, it can be kind of uncomfortable for people because that question is attached to people's bodies. Someone's sex assigned at birth is assigned to them usually by a medical provider who makes that determination by looking at their anatomy when a baby is first born. And because of the nature of this question, right, related to a doctor looking at a baby when they're born, it's really important to be sensitive with this question and ask an open-ended question. And it's also important if someone has a question about what do you mean by sex assigned at birth or sex at birth, that you have a short and concise explanation as to what you mean when you are asking about, sex at birth. And I'm going to discuss an example in our next poll activity. So if you have a question about that, hold on to it. So if you receive pushback based on this question and any question, it's really important that you acknowledge someone's concern, because that concern is valid and we don't want to dismiss it, right? And then you remind them and explain the purpose of the question again, and then remind them that you're asking this question of every single person. That way, that person doesn't feel like they're being, targeted or singled out. So now we're going to go ahead and use a poll question to kind of see how we can best ask this question. So of the options that you see listed below, which is the best way to ask someone about their sex assigned at birth or sex at birth? So a majority of you are correct. So B is the correct answer. And B is the correct answer because this is a simple way to ask about sex assigned at birth using an open-ended questions. It's important the way that we phrased it. What is your sex listed on your birth certificate or your original birth certificate? That's a very simple way of asking that question, right? Without all the baggage that might come with having to explain sex assigned at birth. For people who are transgender, people's sex at birth differs from their gender identity, right? So this is also a respectful way to ask about sex at birth. For transgender people too, some may also change their sex and gender markers in various documents as part of their transition. So asking about an original birth certificate helps to capture that information about their sex assigned at birth or their sex at birth in a way that's respectful. The reason why answer A is incorrect is because you are introducing your own personal feelings into the question, right? And as we mentioned before, you don't want to introduce discomfort where there might not be. And C is incorrect because the category men and women are categories describing gender. And as we talked about, we're talking about sex assigned at birth. So this next slide here, I'm going to go through it fairly quickly. And this is not something that you need to share with the people that you are working with your patients or your clients. It's just so that you are aware of it. And I apologize, there it is. So we want to discuss the difference between sex assigned at birth and gender identity really quickly, because sometimes we use them interchangeably, even though they're very different. So sex assigned at birth is determined by someone, when they're born, by looking at their external anatomy when they're a baby. And that's what goes into their birth certificate. And sex is a complex combination of different biological markers, which includes someone's chromosomes, their hormones, their anatomic characteristics like reproductive organs and genitals. And sex assignment is typically binary, and people are assigned either female or male at birth. Well, someone's assignment of their sex is binary. It's important that we know that our biology is not binary. Chromosomes, hormones, reproductive organs, and genitalia, they exist in a spectrum, and many people's bodies do not fall into that binary definition of male or female. And people who do not fit into that binary definition may identify as intersex, and intersex is an umbrella term that describes people born with any 30 different variations of sex characteristics, which include chromosomes, gonads, sex hormones, and genitals. Usually, though, when they're born, people who are born intersex, they are assigned either male or female at birth. So you still have to ask these questions of everyone that you are interviewing. Gender identity, on the other hand, that's how someone feels about themselves regarding gender. And this is something that changes over time, and it can grow throughout someone's lifetime or even day to day. Gender identity can include how someone relates to their body, but it doesn't always have to. And gender identity is not equal to biological or anatomical characteristics. And some of gender identities that you might know about include man, woman, non-binary, and genderqueer. So now that I gave you a crash course into this topic, we're going to go ahead and have Maria talk about sexual orientation.
Thank you, Luis. So in addition to the gender identity question, the California RVCT form has a separate question about sexual orientation that is also intended to reflect a person's self-identified information. This California RVCT question allows for persons to self-describe their sexual orientation or their sexual identity. This question also includes the options to answer that their orientation is not listed if none of these options apply to the person, as well as also decline to answer this question if the person does not feel comfortable sharing this information. Note that both of these questions about sexual orientation and gender identity in the California RVCT form reflect standardized data options that are collected across communicable disease programs in California's reporting and surveillance system, which is CalReady.
Okay, everyone, I am back. And now we're going to go ahead and do another poll question just to get an idea of how to ask this question. So, which of the following statements is true about sexual orientation? Just go ahead and let us know. And a majority of you answered correctly. Thank you so much for engaging in this poll. So it's important that when we talk about sexual orientation that you understand that every single person has a sexual orientation. And that's a combination of attraction, behavior, and then also how you name that attraction and that behavior. And that's someone's identity. Sexual orientation is not static and it may change over someone's lifetime. Sexual identity is how someone chooses to label that attraction. And people may engage in behaviors for a variety of different reasons, related to pleasure or to explore how they feel or to make money sometimes. And that may not fit neatly into the labels that we use. If you have heard of the term MSM, for example, or men who have sex with men, then you know that not all men who have sex with men identify as gay or bisexual. And that's why answer C is not true. So as you conduct your interviews, it's really, really important not to make assumptions about what your client's or patient's sexual orientation is just because they had previously shared the gender of their previous or current partner. It's important not to make an assumption about someone's sexual orientation based on behaviors that they've told you about, because I remember that identity is not equals behavior. It's always important to ask the person how they want to label themselves, what identity they would like to use. So let's go ahead and discuss a quick tip for asking sexual orientation. So if your interview includes questions about sexual orientation, then here's what you can ask. Usually when you're collecting sexual orientation data, you will ask those that you interview to select one response option from a drop-down list. And we recommend asking an open-ended question like, what is your sexual orientation, or how do you describe your sexual orientation? And if their response matches one of the items on your list, then you can select that option. But it's important that you are transparent, and it would be great for you to let them know that you'll be marking that option that they've listed. And this can ensure that the person confirms that you've gotten that correct answer. So if someone says, if someone says, I identify as straight, and then say, I am, checking the box for heterosexual or straight. That way, you're being transparent and that person can know what you are selecting on your end. Sometimes, though, people might ask you what sexual orientation is, and you can go into the spiel that I just gave you, but we know that your time is very limited, right? So something that you can do that might be easier than having to describe what sexual orientation is, you can just list the orientation options that are listed in your tool and let that person choose for themselves the options that best fit them. And you can see the ones that we have here on your screen. These are the ones that we have access to here in California, but the way that they're formatted might vary depending on where you are. We're not going to review each of the terms here. I believe Gal had posted in the chat that we do have a document where you can, if you are curious and you want to learn more, you can learn, the definitions to each one of these categories. The most important thing, though, is to ask the person, of the ones listed here, which one do you identify with, and let them identify for themselves how they would like to label themselves. We're going to go ahead and do another poll activity, just focusing on a scenario that might happen to you based on this question. So during your interview, you ask someone about their sexual orientation and they respond that their identity or they identify as queer, and your data collection tool does not include queer. So what would you do? Go ahead and let us know. So the correct response here is D. You let the person know queer is not listed. You read out the options in your list, and then you ask them to choose from those options. And this is a great tip for this question in this scenario, but also for any other scenario where what that person lists or shares with you is not listed. So the reason why A is incorrect is because although gay and queer may overlap, gay is an identity that people use to describe who they're attracted to, but queer can describe same-sex attraction, but it is also a word that has been reclaimed by some people to describe that sexual orientation is more complicated than just gay or straight. For some people, it's also a political identity. So it's important that we don't decide what gay or queer mean to us. We want to know what it means for that person that we are interviewing, right? And what identity they use to identify themselves. So when we talk about queer, though, I want to let you know, for some people, especially older people, queer might be seen as an insult. So it's really important to practice client-centered approach to your interview and that you allow your clients to use their own words to describe themselves. So, don't use the word queer to describe someone unless that person has told you that's how they describe themselves. So let's go ahead and discuss D and why that one is the best response. D is the best response because when someone's response does not match an item on your list, or if they feel hesitant or don't know how to respond, the best thing to do is to list out the options available on your drop-down menu. It's important to let that person self-identify themselves and not choose an identity for them. So if someone were to tell you, well, I identify as queer, you can let them know. So queer is not listed here in my interview tool, but I'm going to go ahead and list the options that are available, and you let me know which one fits you the best. And then you can let them know, do you identify as heterosexual or straight, gay or lesbian, bisexual, orientation are listed, and then you let that person know. That person will let you know what they decide. Probably they will let you choose orientation not listed, and that is what you will put. But it's important that you don't make that decision for that person. Let's go ahead and now move into discussing another set of questions that you might be asking about during your interviews. And Maria is going to go ahead and walk us through that.
Thanks, Louise. Let's go ahead and jump into the next slide. Okay, so the ethnicity question in the RVCT form should be based on a person's self-identity or self-reporting and not based on physical appearances or surname like Louise was describing. If the person identifies as Cuban, Mexican, Puerto Rican, South or Central American, or of other Latin American culture or origin, regardless of race, then Hispanic or Latino may be a more appropriate answer for this question. Otherwise, you can select not Hispanic or Latino, or even unknown if the person's ethnicity was not provided here. Like the ethnicity question, the question about race in the RVCT should also be based on a person's self-identity or self-reporting, and again, not based on physical appearance or surname. A person should also be offered the option of providing more than one racial designation. For the race question, the RVCT form also includes these additional person race categories for Asian and for Native Hawaiian Pacific Islander. Next slide, please. Okay, so here, if a person self-identifies as either Asian or Native Hawaiian Pacific Islander, please respond based on all the options that apply among the person race categories. And if a person self-identifies as another race that is not listed, you can include that race that they self-report in one of these specified free text fields. And again, note that this video is an example of how the information from a client interview, a TB case reporting form, may be entered and reported into the RVCT form for persons who identify as multiple Asian races or multiple Native Hawaiian Pacific Islander races.
Okay, so now we're going to go ahead and learn a little bit more about race by doing an ethnicity by conducting a poll. So which of the following statements is true about race and ethnicity? Go ahead and let us know using the poll that's in your screen. So this one is also another one that is a little bit more controversial for people here in the group. So the correct answer here is C. So race is a social construct like Lisa mentioned. So it's important that we know that race is not biological or genetic, but it's a social label that is based on, what we see, what we can see, characteristics of people, skin color, sometimes also culture or location of ancestors. So this is just a social interpretation of how someone looks. And when we say that race is socially constructed, is what we mean is that the categories that we use for race and the importance that we give them in our society, those are created and they're reinforced by our society. So it's really important that we know that that does not mean that the effects of racial privilege or racial discrimination are not real. What we're saying is that the way that our society is structured around race, that is constructed by our society. An example of this is that the way that we think about race shifts. It depends on the context. So how people from different regions or cultures have been categorized related to race in the United States, it has shifted over time. And it relates to access to power and social and political context. So for example, previously, different generations of immigrants from Europe, like people who are coming from Ireland or from Italy, they were not considered to be white. But now in our modern context in 2024, they are, right? So that shows you that race is socially constructed. It changes over time. It is not about biology, but about the way that we label the people in our world. Like Maria mentioned, there's a difference between race and ethnicity. Although sometimes we use them interchangeably and sometimes they do overlap. But ethnicity is more about based on a shared culture, so shared language, food, music, dress, values, and beliefs related to someone's common ancestry. And it's important to know that these categories are, like Maria mentioned, self-reported, and that people who identify with more than one race may choose to provide multiple races in responses to their race question, like Maria talked about. So a helpful tip when discussing race, the race and ethnicity question can be pretty tough for people who are Latino or Latinx or Latinx. Since race is socially constructed, we know that, and it's separate from ethnicity, people from a Latino background, they can be of any race. So that's why it's important to ask ethnicity and then follow up with race, because people who are Latino could be Black, they can be white, they can be Asian, they can be of mixed race. So it's always important to ask all the people that you interview this question and that they have a choice of how they would like to self-identify. Never make a choice on someone's behalf. That's a key message for our time together. Always ask the person what they would like to self-identify. And for Latinx people, that race question can be difficult to answer, like I talked about. They can select more than one race category, and that's true also for everyone. And I do want to let you know one important thing is that the category American Indian, that category encompasses all of the Americas when we talk about America, according to the CDC, the Census Bureau. It includes North, Central, and South America. So that's an important caveat to know about. As well as people who identify as Latino, like with other people whose identities are not listed, they can list for themselves identity not listed. So we're going to go ahead and shift gears, and we are going to have Maria take us through some other questions in the RVCT.
Thank you, Luis. So we're going to shift to the questions in the RVCT that include resident of correctional facility, homelessness, and drug and alcohol use. So the RVCT question does have two questions about a person's incarceration status. They're a little bit similar, but also different. So the first question asked if the person was ever incarcerated or detained in jail, prison, or any other detention center at any point in their lifetime, whereas the second question asked if incarceration occurred when TB diagnostic evaluation was performed or initiated. And here for both of these questions, the response options include yes, no, or unknown. The RVCT also has two separate questions about homelessness. The first question asks if the person has ever experienced homelessness at any point in their lifetime, whereas the second question asks if they have been homeless within the 12 months preceding TB diagnostic evaluation. Again, the response options do include yes, no, or unknown. So these are going to be some of the most common response options with these other RVCT questions that we're reviewing. Okay, now we have two questions about drug use in the RVCT form. The first RVCT question asks about injecting drug use. For this question, injecting drug use involves the use of hypodermic needles and syringes for the injection of drugs that were not prescribed by a healthcare provider. Again, response options in the RVCT do include yes, no, and unknown. And then here we have the second RVC question that asks about non-injecting drug use. For this question, non-injecting drug use involves the misuse of licensed or prescription drugs, which could include opioids or other drugs that were not injected or prescribed for the person by a healthcare provider. And this question also includes those drugs that were not FDA approved for over-the-counter use. And here for this question, drugs may be either ingested, inhaled, sniffed, or smoked. And then lastly, the RVCT question about heavy alcohol use is based from the National Institute on Alcohol Abuse and Alcoholism, which involves binge drinking on 5 or more days in the month preceding the TB diagnosis. And again, the response options include yes, no, or unknown.
Thank you, Maria. So here, just a couple of general tips for asking about risk factors. So again, it's important that you share why these questions are being asked. And that's the case for all the questions that, we have been discussing about during our time together. It's also important to let that person know that you ask these questions of everyone, specifically when we talk about things that are stigmatized, such as, being incarcerated or having experience of being homeless or, using substances. It's important to let that person know that you ask these questions of every single person so that they don't feel like they're being targeted based on an assumption that you're making. For questions that have to do with substance use, about incarceration, or even immigration status, it's important to let that person know that you do not work for and that you do not report to their information to law enforcement or immigration. Before you even start asking those questions, it's important to let people know that so that they feel a little less concerned and they can feel a little bit more comfortable with asking those questions. So our suggestion is that before you get to this kind of risk questions, that you make a statement separate to the statement that you would have made at the beginning of asking demographic questions. Something like, the next questions involve experiences of incarceration, substance use, and immigration status. Please know that we ask these questions of everyone that we talk to. As with all our questions, we want to understand who is most affected in our communities, and that is why we're asking you this demographic questions. And then you start by asking the questions, and that can hopefully answer some of the concerns that people might have when you get into these questions. And of course, let them know the information will be kept confidential. We do not work for law enforcement, and we do not provide your information to law enforcement. So some overarching last tools to remember to use when you're asking these questions is to ask questions open-endedly. Again, open-ended questions, those are the ones that people have to answer for themselves. And as we talked about, we want to hear how people self-identify, right? That's important. So you can ask, do you identify as Hispanic or Latino? How do you describe your race? How do you describe your gender identity? What is the sex listed on your original birth certificate? And how do you describe your sexual orientation? Those are examples of open-ended questions that you can ask someone to get the information that you need for filling out the demographic data collection tool. So now, something that we heard from a lot of folks as you signed up for this, this webinar was dealing with emotional reactions. Many of these demographic questions may lead to people having difficult conversations, as well as be reminded of uncomfortable feelings or situations that they've experienced in the past. So for some, these topics can be interconnected with past experiences of stigma or discrimination or trauma. So it's important that when you hear someone have an emotional reaction, that you show empathy for that person and that you also show compassion. So next, I'm going to go ahead and share the HEAR technique, which is a tool for you to be able to use to listen and also to respond to concerns that the people that you're working with, your client, your patient, is sharing with you when they have an emotional reaction. So here's the HEAR technique, and I want to remind you that you're going to have a chance to download the slides, so you don't have to take note of everything that's here on the screen. You'll have that available to you on the website, like I'll mention. The HEAR technique is a health coaching technique that was developed by the California Virtual Training Academy to de-escalate emotional conversations. And when it was developed, it was used to de-escalate emotional conversations regarding COVID-19 vaccination. But the steps that are involved here in this technique, they can help you listen and respond to someone's concerns while de-escalating the situation on multiple different issues or concerns that people might have. The HEAR technique stands for HEAR, which is the first step, express attitude, answer and ask questions, and respond. So I'm going to go ahead and review with each one of them with you. So the first step is to hear. You ask open-ended questions to invite the person to share their thoughts and feelings, and then you reflect back their words so that they know that they have been heard. So you can say something like, so it sounds like you're concerned about confidentiality, or, tell me more about the feelings or thoughts that you're experiencing. Then the next step would be to express gratitude. You can thank the person for sharing their thoughts openly. You can say, thank you so much for sharing that with me, or I appreciate your willingness to talk with me today. And it's important that when you express attitude, that you express it in a genuine way, that you find something that person that is truly that you appreciate, because people can definitely tell if you are coming from if you're not being honest about the expressing gratitude with them. Then you go ahead and you move into answering and asking. So you answer any questions that the person has, right? And you ask permission to share your own knowledge and perspective. So you can say things like, what questions do you have for me about how this information is used? Would it be okay if I share some information about how this information is used with you? And then once you have gotten permission from that person to share information, you can share key information and then discuss next steps. You can say something like, let's talk about how your responses to our demographic questions are used and how that information is protected and kept confidential. So that's the HEAR technique in a nutshell. And we have some tips that you can, look at on your own. What we're going to do now to show you how easy it is to apply the here technique is really quickly go over an example with someone um, who has been exposed to TB. So Dre was named as a close contact to a person who was diagnosed with active pulmonary TB, and a disease intervention professional, one of you, is out there interviewing Dre over the phone or maybe in person. And this disease intervention professional is collecting demographic data during Dre's interview. So we're going to see now how that conversation might go. And I'll be reading the role of the disease intervention professional, and Maria would be playing Dre. Dre, like I mentioned earlier, the question I'm asking in this section of our interview helps us ensure that we provide the best services to all members of our community. How does that sound?
That's fine. I didn't love talking about my sexual orientation with you, but it wasn't that bad.
Thank you again for sharing your responses, Dre. I hear you when you say it can be uncomfortable to answer those questions.
No problem.
Thanks, Dre. I'm going to start with discussing substance use. So in the past 12 months, have you used drugs?
Whoa, I don't want to answer that.
Okay, and now we want to hear from you. What should this disease intervention professional do? What should I do? Go ahead and let me know by answering the poll. And I'm glad that we're all on the same page and that we're going to try to use the here technique. So let's go ahead and end the poll because we all agree this is a perfect example to use the here technique. You are all correct. So let's see how I applied the here technique with Dre. Dre, it sounds like you have concerns about answering this question. Please tell me more about that.
That's just real personal. It makes me uncomfortable.
Dre, thank you so much for sharing your concern. It sounds like discussing this with someone you don't know is making you feel uncomfortable. I apologize for making you feel uncomfortable. To help me prevent from making you feel uncomfortable this way again, what concerns do you have about discussing this with me?
Like I said, I don't know you, and I'm not sure what you will do with my private information. You work for the government, and I don't want that to be in my record.
Thank you for sharing with me more about your concerns, Dre. Can I share some information to address your concerns?
Sure.
Okay, now we want to also get your help with how to answer this question. So what should I do? Go ahead and let me know by answering that poll. Our recommendation is to share with Dre how this data is protected and describe how it's being used. And the reason why we think this is the best approach is because this is what Dre specifically has told us, right? Dre told us that they're concerned about how this data and this information is being used. We don't think that highlighting that this is important for health equity. That's not something that Dre mentioned to us, right? We want to definitely target our information to address the concerns that the person is informing us. So that's why we think B is important in the way that we could answer. So let's see how it goes. Dre, first, I want to let you know that I asked these questions of everyone, and your responses are confidential and are not shared with law enforcement, including parole officers and immigration. How does that sound?
Really? Even if I talk about illegal drugs?
What we discuss is protected under local, state, and federal confidentiality laws, including HIPAA, which makes it illegal for me to share your medical information without your consent.
Okay, I guess it's cool.
Maintaining your private information, Dre, confidential is really, really important to us. So thank you so much for letting me address your concerns. So I'll go ahead and ask you that question again. So in the past 12 months, have you used drugs?
Yes.
Okay, thank you, Maria, for playing Dre. Hopefully, we win Academy Awards for our performances. Probably not. We can stick with our day jobs. So hopefully you have seen how easy it is to apply the here technique when someone has an emotional reaction. I'm going to go ahead and start wrapping things up by just doing some housekeeping and putting this all together. So here are our final recommendations for collecting demographic data collection. So do ask every question of every client. This reduces the impact of any biases that we might have and might not even know about. Make sure that you do remain not judgmental. Remember that tone of voice is really important. How you phrase your questions is really important, and how you receive that information really goes a long way. So if you're in person, make sure that you have a neutral face, that you're not making any judgmental facial reactions, that you just take that information in a neutral way. Do make sure that you practice, do say the response options if the client is unsure, list the options if people seem unsure. Do make sure that you practice until this feels comfortable for you. Remember that practice makes perfect. Sometimes if people hear our discomfort, they may mirror that discomfort back to us, even if they themselves don't feel uncomfortable by asking those questions. So practice with your kids, with your coworkers, with your partners, with your friends, even your dog, if your dog is willing to listen to you asking those questions. Practice until you feel like you are not changing your tone of voice or your cadence when you're asking those questions, and until you feel comfortable, asking those questions. Do also know how to quickly state the rationale for these questions. Have the reasons why you're asking these questions in the back of your pocket, so you can, just share that with people. And when you share that information as to why you're asking those questions, make sure that you're confident, that you're concise, and that you're clear with what you're sharing with that person. Lastly, don't say that these questions may make you feel uncomfortable. Again, this might bring discomfort where there is none. Don't assume a response to an option. Remember, never make an assumption. Always ask the person to identify themselves. Don't import data from clinical records. We don't know who entered that data, right? Clinical records could be riddled with assumptions that someone else made, someone else's biases. Also, the way people identify is fluid, right? So it may change over time. So we want to collect the most recent information about how that person identifies. Don't take it personally also if the client gets upset. They're upset because these questions can be uncomfortable to answer, right? So just be empathetic, practice the HERE technique, and see how that goes. If you do still feel shaky, that's okay. Asking this question takes practice. So before we end and start the Q&A, we want to let you know that we have compiled a few resources. I won't go into them in detail. They'll be listed in the website that Gal will tell you a little bit more about and that they have shared with you. They include, different documents that have more information from the CDC about the RVCT questions, as well as live and online trainings that you can take in addition to this webinar, so that you can learn more about how to ask these questions of the people that you're working with. So I will go ahead and now turn things over to Lisa. So Lisa, let us know, what questions do folks have?
So much, Luis and Maria. It's really, really great presentation, full of a lot of good tips and skill training. So I'm going to start with one of the questions that was not posed as a question, but I think brings on its own questions. And so what I'm going to do is what we just learned we should never do, which is make some assumptions. The statement is this: many immigrants do not understand this question. And this came up during the time when you all were talking about gender identity and sexual orientation and sex assigned at birth. So the assumption I'm going to make and turn it into a question is, how do we address some of these questions when there really seems to be the client may really just not understand where you're at. So translation may be challenging, for example. Maybe you have a translator on the phone, right, who's talking to your client. How would you address that?
Yeah, so when especially let's take the example of sexual orientation. If you're working with someone, either a translator or directly with someone who's tells you what is sexual orientation, then you can let them know, sexual orientation is, what the word that people use to describe who they're attracted to. Sometimes you just kind of have to explain it and unpack it a little bit, and then you can ask the person, you can read the list of questions of options to that person, right? Sometimes you might have to let them know. So what this means is that we are just asking, who you're attracted to. Who you're attracted to, and then you can ask that question open-endedly, right? And then if depending on what they say, right, you can say, well, the options that we have available that would mostly correlate with this answer. How do you feel if I list that or mark that as your answer? That way, you are walking someone through the different answer options, but at the very end, it is their choice as to how they would like to identify, but with a little bit more support from you, because some of those terms might not be, those terms that people might use depending on where that person is. There are LGBT people all over the world. They might use other words that are not the words that we use. So it's important to still ask those questions for people, and we not make a decision just because of our preconceived notions of like, oh, wait, they don't have that over there. They do. And it's going to be really unfortunate if for people who are LGBT and are immigrants, if we don't collect that information for them, because then we're double marginalizing them as immigrants and as people who are LGBT. Hopefully that was helpful.
Another live question is from a participant who said, regarding poll question number 5, what if we read all of the options and the client still does not choose any of the listed options that we give them?
Yeah, that's a great point. And I don't remember exactly which poll was number 5. It might have been related to sexual orientation, maybe, or gender identity. But if someone does not, if you ask them repeatedly, right, then you can always let them know. Is it okay if I list identity not listed? And then like that person can choose for themselves. Yes, that's fine. And I would ask, Maria or Lisa, the response unknown should be left for when someone wasn't asked that question, correct?
Correct. At least in the RVCT, there's the option of orientation not listed, identity not listed.
Thank you.
I also wanted to point out here that, again, in California, we are limited to our options based on our CalReady system. So sort of the technology underlying the ability to collect these data at the state level, local and state level. And just recognizing, in recognition that the terminology changes through time. In fact, the American Medical Association put out some guidance, and there's a work group that is consistently kind of revising these categorizations because it does change with time. But getting back to this idea of CalReady is a little delayed in terms of adjusting to new terminology. And so, for example, this absence of the terminology queer is not something to be changed easily, but perhaps in the next iteration, it would be one of the possible options at a future date. Okay, I'm still checking the time, 12:23. One more live question I think we have time for. And as I said, if I didn't get to your question, we will do our best to answer them in writing. This question is, what if the person is adamant that they are human as their race?
Yeah, thank you so much for asking that question. I would, let that person know, thank you for letting me know. That option is not available. How do you feel if I choose identity not listed? And then again, you can let that person decide for themselves if that is the best fit for them.
Okay, so how about this one? Many patients ask why we need to know such personal information. What is the best answer to give?
Yeah, thank you for sharing that. I can jump in, but I think Lisa's presentation really was gave us such rich information. You can let the person know that these questions are used to understand how TB affects, different communities, And there's a lot of things that we don't know about how TV affects those communities, right? And the only way that we would know is by having this information. And then follow up with, what concerns do you have? Because what's most important is to, hear what specifically concerns them and then try to address it, because everyone's concern is going to be different. Someone's concern could be about confidentiality. Someone's concern could be, I just don't feel comfortable, sharing this with you. It could be a variety of different reasons, and the way that you address it is different for each person. I don't know, Lisa, if you want to share a little bit more, since this was kind of like the meat and potatoes of your presentation.
Well, I think you definitely have it, Luis. That's exactly the point. Is that the hope is that we are addressing your needs as best we can, and we collect all of the data, not just these specific questions, but all the data that I've been talking to you about today, for the purpose of improving care in the future, for all communities, where we live. So another question, this is sort of interesting. Can thanking someone repeatedly for their concerns eventually be viewed as insincere?
Yeah, that is a good point. So I would say you could pepper the thank yous. I'm someone who is very to a fault, thanks people for every statement that they give me, right? And that makes some of my interviews longer than they should be. But you can definitely adjust to how you feel that person is receiving the information. So if you feel like they just want to move on and they, have time pressed against them, then maybe just pepper them in a little bit throughout your interview. And like I mentioned before, make sure that thank you is comes from a very sincere place. So if you feel like you're just saying it to kind of fill up time or space, just say it when you really truly mean it. And hopefully you'll find a couple places where you really do, and you are thankful for them sharing with you how you can help them move through the interview.
One of the questions asked about binge drinking and across the board, the way its definition is the definition across the board for both men and women. I think they were pointing out how maybe for men it would be one drink more than for women, for example.
Yes. So, based on the definition for binge drinking, it's just a pattern of drinking that brings the blood alcohol concentration levels to a certain quantity. And so, yes, so that typically can occur after 4 drinks for women and 5 drinks for men in about 2 hours.
Okay, well, I think that's all we have time for questions. Thank you so much for you all showing up today. Really appreciate all the questions and interest.